So today we're going to be going over difficult airway, and we'll look at a couple of the different options that come up, all the way from the algorithm to some of our alternative and rescue airways, all the way and then some different methods that we can use, such as the salad technique, all the way to cricothyrotomy. So that's going to be the overall kind of structure of what we're looking at trying to go through today and doing that. So we'll start here, look at our algorithm. And so the first thing we're going to look at is the difficult airway algorithm. I've modified this slightly and just made it easier to look at for us. This is nothing crazy. This is the same you'll see in your book or very similar. No big changes. The difficult airway algorithm is more or less the same across the board. Occasionally you'll see few changes here and there, but this is where we really start looking at what causes, where we can identify difficult airways, which we're going to go ahead and look at with that with either heaven and lemon, which is in our top two, the top corners in those rectangle boxes, and that's going to be heaven, hypoxia, extreme to size, anatomic, so any type of anatomical changes, short neck, interior neck, things like that, vomit, blood, fluid, things of that nature, anything that can cause that to be more difficult to deal with, extenuation, and then the neck itself of being short, long, any issues like that. So lemon's going to be look at airway, evaluate, and Mallampati, obstruction, and so this, and then neck mobility, all very similar. And so neck on heaven is kind of the same, that neck mobility issue, and they're pretty similar in nature. Kind of look at a couple different aspects of it, but more or less pretty overall the same things that we're going to be looking at between heaven and lemon, and they're just two different algorithms to go over on either of those. So the first one would be your first attempt. You've identified that it's going to be a difficult airway. You're going to assess, hey, short neck, vomiting, blood, trauma. We have them in a C color, things like that. Once that's identified, as soon as we note that it's a difficult airway, we should be look at getting our more experienced intubator there, especially depending on what exactly it is, or be ready to escalate things if needed. We should be looking at trying to do everything we can to really get that first pass attempt success, and kind of go with that. So as soon as we get our first attempt in, then we're going to, if we failed that first attempt, we're now looking at, we have to change something. It doesn't matter what it is, but we have to make a change. If you get in there and you notice that all of a sudden you had a very vomit-filled or blood-filled airway, all right, let's get suction in there, maybe go salad technique. Maybe you didn't realize it was going to be anterior until you did your initial laryngoscopy, your first attempt. You go, oh yeah, this is a really anterior airway. Maybe I'm going to look at a hyperangulated video blade, something else, change something. It could go from a Mac to a Miller. It doesn't matter what. It doesn't have to be a huge change, but don't do the exact same thing. Even if that's same, you could have all the same equipment, but if instead now you're going to get some suction in there first, any of those is a change. But if you need to make a change to try and adapt to what the issue is going on now, and so once we do that, we're going to try our second change, our second attempt. That second attempt, we will then look at, hopefully get that. If we still have a failure at this point, we're going to see if we can still oxygenate and ventilate via BVM or supraglottic. So BVM is not quite on there, but if we can BVM any of these patients successfully with no issues, then we can still ventilate. If we cannot, when the supraglottic doesn't work, whether it is it's a burn, upper airway obstruction, something like that, and we can't ventilate, or it could just be the patient themselves. If we are not being able to ventilate our patient, at that point, we're moving to our last option, and that is a cric. The interesting thing is, if you follow a difficult airway algorithm, and you now get here, you shouldn't no longer think about it. If you can't ventilate, you can't oxygenate, and you've tried 2 attempts to intubate and you still can't do it, you don't have to worry about making the decision to crike. The decision's made for you. Go ahead and just go down that route and do what you need to do. Um, there's plenty of people that have gotten a crike and survived just fine. But if we don't get that, if we're not able to ventilate, they are not going to survive. Many times a crike seems very invasive, and it's a pretty invasive procedure. Do have a video of one coming up here. Being said, once you hit that, you can't ventilate, you can't oxygenate, and we've attempted to intubate twice and we can't get there. Or you might go in and see that airway swelled shut, or for whatever reason you go, I'm not going to get, if on that first attempt you realize you're not going to be able to get a tube, you can immediately move to the intubation. You don't have, or to the cricothyrotomy. If you realize, like, hey, this is a burn, I took one look and everything's swelled shut, there's no way I'm going to get a tube even with the second one. Don't mess around with the second attempt, just go for the first. And then this algorithm makes it real easy, and if you follow this, that is basically what we're supposed to do. Difficult airway algorithms are pretty simple. There's not a lot to them. Work down the algorithm. Once you're in that next spot, go. Much like even if we're defibrillating, you go down your ACLS algorithm, get the spot we're supposed to defibrillate them. We don't make second guesses. No, that's the spot where we're at. Use it. All right, we're going to quickly go over supraglottics. We went over this a bit before in class, but supraglottics are anything that the airway is above that glottic opening or the cords. ET tube is a subglottic or inferior. It is the gold standard. Some of these work better than others in certain conditions. Some of them are very effective to isolating the airway. A couple of those are, particularly the King, but the King has a couple other issues, such as increasing the pressure, the huge amount of air that goes in there, and we'll take a look at it, puts pressure on the carotids, which decreases blood flow to the brain and then back down to the heart. So there's a couple of issues with the King, even though it's probably one of the better supraglottics from a pure airway perspective, but it has other issues, and it's one of the reasons it's not widely used. Combi tube's there. It's a device. The rest tend to be LMAs of some nature, or LMA-esque, like the iGel. The rest, the AirQ, things like that, are variations of an LMA, and so is iGel itself. So, LMAs, it's a laryngeal mask airway. It's basically a BVM that goes directly in your larynx and just covers and semi-isolates the glottic opening from everything else and allows us to put positive pressure directly over the larynx. It's more or less a BVM that just goes in. It's not a true advanced airway. Can it be sufficient many times for cardiac arrest? Or if you're not, if the airway is working, it doesn't matter what airway it is, BLS, supraglottics, or ET, you don't need to change it if it's working. But when you're having that failure to ventilate, that's when we need to go to the next more advanced airway that we have. So iGel has a bunch of things. Some of them have the extra little oxygen, supplementary oxygen port, or the ability to suction through those. Some of them don't. But in general, they all act the same. It's all the same company. Some of them, there's just a couple different models of it. It has a built-in bite block, has a built-in OG suction. That OG is meant to go down into the esophagus to decompress the stomach. And then if you need to suction out from the iGel itself down to the trachea, just go down the normal tube. Overall, cool thing about nice thing about nigel is the pressures don't change on that, and that gel-like substance around the mask portion of it on that lower part, it warms up and creates a seal when exposed to body temperature, and so it'll warm up and it's supposed to create that seal. Not necessarily as good isolating, same as any of the LMAs, isolating the esophagus from the stomach, because gastric content can come up still and bypass that mask. It doesn't take very much to just lodge it. So while it can be a semi-effective airway, other times it's not that effective, and we need to get an ET tube. So if you're having a hard time ventilating, or it doesn't really isolate the airway from the esophagus at all. This is the King LTT airway. Pretty decent airway for like I said, for just that airway aspect of things. But as we can see, that balloon takes a lot of air. It's something between those two balloons, the distal and the proximal cuff, somewhere around 75 cc's air, depending on which model you're using. And you can tell it just puts a lot of pressure on the surrounding tissues. And that pressure, one, can sometimes affect the vagal nerve, as well as put pressure on the carotids, which decrease blood flow to and from the heart and the brain. Can be an issue, particularly in head injuries. So, pretty decent overall, because it does isolate the airway better than almost any other supraglottic. Being said, it has a number of its own issues. So, like any device, it has its plus and minuses. We had these out for a bit, and then they kind of went away. Use of this before the airway is inserted, needs to fill up the cuff to see exactly how much it needs to be really filled. And because many times it'll come with 60 or 70 cc, sometimes 50, depending on the size, and just see how much is actually it needs to be filled. Typically, it'll have something on there to say how much cc's of air you need to push into there. And then, like any other device, any airway device, anytime we have a movement of the patient, we need to assess the efficacy of our airway and how it's working after a movement and if it's still in place. So, combi tube, esophageal tracheal combi tube. It's combi combination. Not my favorite device. There's a decent reason why I have this. Some of it's anecdotal, but there's also a reason it's not on our truck. And when I mention some of the anecdotal stuff, it's because we still have to train to it. But in my experience, I've not had the greatest with it. It works relatively well. The issue is there's a lot of parts to it. And typically when you're in a situation where you're using a supraglottic, you don't always have a lot of time to be trying to re-figure out your device. Nice thing about an iGel or even a King is that in general, it's a bit of a one, put it in there and you forget about it, blind insertion, not much thinking about it, getting onto other things. That's why it's useful in cardiac arrest, and that's why it's useful as a rescue device. The issue with a combi tube, if those of you guys who don't really have any experience using them in the past, is that the combi tube has two tubes you need to use to insert, or sorry, it's one tube with two areas that we will attach a BVM to. The issue that comes to is trying to remember which one is first, what do we need to do to try and make sure that it is working effectively, and what tube it's going. The reason it has two tubes is one of them, hence why it's called an esophageal tracheal combi tube, is that it's a blind insertion device, so technically it can go in either hole, either the trachea or the esophagus, and depending on which of the tubes you connect to the BVM is going to be where it is. So it's meant to be that if you put it in there and you accidentally stick, or if you get a tube somehow in the trachea, well, now you just have an ET tube that is, however, 90% of the time it seemed to always go into the esophagus, as that's where your body naturally wants to put big foreign objects in there. That's why your trachea is typically more anterior, and why you tend to not just be able to blindly stick any tube in a hole and magically get there. So the issue that kind of comes with this is that you have to try and remember which one's first. It's blue first. But you're in a situation where you're dealing with a tube or a airway that you're now moving to a rescue type situation in. You're usually having a lot going on because your patient has a failure to ventilate, failure to oxygenate type situation. You're trying to get them going, or it's a code, and you're trying not to overthink, like have deep thoughts, trying to figure this out. You're trying to go. And so the idea is to go in one. It's labeled, but then you're now isolating. Now, the nice thing is it does isolate pretty well, much like the King. There's just a couple extra moving parts, and the reason I don't is just it's not a time where I want to be trying to remember. And usually where iGels are used all the time, it seems these days, combi tubes were not used that often because they're kind of a pain in the butt to use and to remember how to use. If once they're in place and you're oxygenating the right tube, everything like that, it works just like any other good supraglottic if it is working. And so it's It's an airway. We'll leave it there. It's a supraglottic. Not my favorite, but it's there, and definitely one. If that's all you have, if wherever you're working, it is an effective supraglottic. You just have to make sure you're staying up on the training, um, and using it like you should. So it works. It's blind insertion. Put it in. Fill one cuff, then the other. In the order that it says on there, typically it tells you. We have them in class. We'll go over them. The use of them. It's paramedic. It's national standard to know those. You just see that they've kind of fallen out of favor because the iGel and AirQ types LMAs are a little bit more effective and easier to use, particularly in these stressful situations where you use them as a rescue airway. All right. The first thing they try and do is they try and breathe through the end hole and the esophageal lumen. So it's a dual lumen as it goes in, and if that works, then that means you somehow got in the trachea. Cool. And then you still check like we would any other one. If the first one you're not getting lung sounds and you're getting esophageal sounds, then switch to the number 2 and use that one. It works. It's been since the last airway class since I've gone over these, and I've only used them a couple times. Like I said, it's an airway, and if it's what you got, it works. Good enough, and it does work when it's in place. So. Yeah, some more on the combi tube. So now we're going to move to ET, intubation, and some, particularly in the difficult airways situation. We've already practiced in class. We know the basic procedures. We've used most of the different types of blades, particularly the standard blade sizes, but the advantages of ET over a combi. So if you ever have a discussion like, oh no, combi's pretty good. A combi's not an advanced airway because it doesn't do some of these things. It provides complete airway control. There's a reason it's the gold standard. It helps prevent aspiration because it does not. If that balloon is fully inflated, it completely isolates the esophagus unless there's a esophageal tracheal fistula or tear in there. With any type of normal-ish anatomy, it completely isolates it and prevents gastric contents from getting into there. And that is one of the primary reasons people get intubated in the field in general, is to isolate the esophagus and the trachea. So it prevents gastric distension. Gastric distension leads to vomiting, which leads to aspiration. And it's positive pressure ventilation can be and usually is almost always delivered, particularly in our case. It came up in one class discussions, but usually, like, yes, a patient can have an intact respiratory drive and just use that to secure the airway itself. But in general, we are using a BVM attached to the end of an ET tube, and we're assisting their breaths as needed. Even if they have an intact respiratory drive, we're usually breathing. Now, the other things it allows us to do is completely control the tidal volumes, the rate, PEEP, all these things, because we're getting rid of a lot of dead space. With that, we're losing a little bit of dead space. So the volumes that you might get with a normal BVM with a tube, all of a sudden we're not pushing the air through that big open space of our mouth, the upper airways, all this. We have a lot less space, so just be a little bit more cautious of barotrauma with this and tidal volumes given. With an ET tube, we can worry about a little bit smaller breaths. However, that also being said, because we completely isolate it, the air has no place to go but to the lower airways, because we're forcing it in that direction. And when we do that, we're not allowing any of the air to escape, and we have a higher chance of barotrauma by increased pressures and increased volumes. It does allow tracheal suctioning. You can do that with most of the supraglottics, but it allows us to get in there and suction out a excess amount of fluid, mucus, things like that. So large volumes of inhalation, if that's what we're aiming for. But in general, the other thing it definitely allows us to do is the pressure and the high concentrations of oxygens really being able to affect the PIP and the PEEPs. So the ability to recruit new alveoli and keep the other alveoli open from atelectasis. So It's a really useful device, and it really helps the oxygenation, which is the other reason when we're working on trying to isolate or oxygenate our patients that are having difficulty. One of the reasons that you might see why we used to intubate so much was CHF patients, because we had to get PEEP into them. When the advent of CPAP, all of a sudden the intubations, we actually dropped quite significantly in the pre-hospital. And this was all the way back in 2012, 13 areas when we really started getting CPAP. And now we're starting to see BiPAP, which tends to be even more effective, particularly at just improving oxygenation in general and improving atelectasis and ventilation. So this, we don't see it quite as much, but the other thing it allows us to do is completely isolate the airway. When COVID hit and they weren't sure everything was going on, and we were transporting around in tiny little helicopter cabins, we were having them intubate all of our patients prior to leaving. Either we would or we'd have the facility do it, and most flight companies were, because we weren't exactly sure, because it really allowed us to isolate that airway and help with different types of infection control as well. So, and it can be a route for some drugs. Also, another technology, the IO, really helped kind of get rid of this, because it wasn't the best delivery device. But what we would do, and we're not just talking nebulizers. So what we used to do is just put a bunch of epi down the tube and then breathe for our patients. Once we started breathing, it wasn't really nebulizing. It just pushed it, and it would cross through the alveoli. It worked, but as you can imagine, putting any type of fluid is not always ideal into the lungs. It was a semi-effective method, but with the advent of IOs, we can almost always get one. There is still protocols typically around to give medications via the ET tube route, but they've kind of just gone away because people just don't use them anymore because we have IOs. So some things changed due to getting CPAP and IOs, and other times we're going to gain or lose things because all of a sudden they find evidence that it wasn't working as well. And sometimes a little bit of combo of both, like the ET tube medications, although it still is a way. And you'll see other medications given in, say, neonates, and we talk about neonates, that they'll actually deliver surfactant directly via ET tube. And sometimes that's the only reason they'll tube those tiny little babies, is to deliver surfactant, and then they'll withdraw the tubes, or sometimes they'll keep it in, just especially if they're going to know they're going to need multiple, or the baby wasn't breathing very well on their own. So another reason that we'll give medications. All right, so we're going to talk about a couple of alternate intubation techniques. We should have practiced some of this in class if you weren't there or haven't got to it yet. The digital intubation is actually still used a bit. One of these, the nasal intubation's not really used that much, particularly with the advent or use of induction agents, paralytics, and other things. We'll talk about nasal here in a few. But that all still being said, digital can be relatively useful depending on a couple different things with that. Positioning, maybe they're still in a vehicle that's being extricated, and they're using that as because that's the only way they can get a good reach, or be able to get that airway, because the patient's losing their airway and they need to try and support as best as possible. And so it might be that reason. Sometimes it's just a weird positioning. It could be because they're in a C collar. If you have a hyperangulated blade of either the King or the X blade for the McGrath, those kind of take away that. And so this is another one of those things that's kind of gone away. You still see it occasionally, and it does have its uses, but not nearly as much as in times past. This was a typically a device, and one of the coolest ones I ever heard was TRT guys out in Sedona Fire. One of the guys I went to medic class with said his crew members said one of the coolest ones ever. A car was hanging off the side of a cliff. The TRT medic had rappelled down and was providing some basic care. Recognized that the patient was losing their airway, and basically, while upside down inverted, digitally intubated a patient in the car hanging off a cliff. If that was me, I would go ahead and just hang up my uniform, be done, because I'm never going to top that. That's one of the coolest airways I'd ever heard. Just rappelling, hanging down, getting a guy hanging off the side of one. But can be used basically if you stick your fingers and you find their trachea and their epiglottis, and then you put the bougie or tube between your fingers and then advance it through the trachea. This one's still decently practical and used occasionally. Certain disasters and tactical situations. When I did tactical meds, we didn't carry ET tube blades. We might have one back in our med truck, but in general, in our main bag, we typically didn't. We either carried epiglottis. We had ET tubes, and it was either for this or for crikes. So it was either a supraglottic or a crike, which is our kind of go-tos, but you could also digitally intubate. And that was one of the ones that where you'll see it too. In a disaster situation, many times you have less supplies than you have you might not have all your supplies with you. You may run out of certain things, certain situations. So this is another one where you might use it in a more disaster meds type situation. You're out in the middle of nowhere, things like that. Wilderness, use that too. Um, and so we kind of went over that. We did the skill in class. I'm not going to spend too much time on it today, but it's useful. So here's some more pictures of digital intubation and kind of the process behind that. Like I said, it's effective. It works. Is it one you're going to use maybe your entire career? Maybe not. But knowing it and knowing how to use some of these skills is important. All right. Nasotracheal intubation. This is one that has really gone out of favor, particularly for a number of reasons. One thing that reason it was used in the past was it was a way to intubate someone to be awake. And in fact, tracheal intubating a patient, technically one of the indications has to be that they have an intact respiratory drive. They don't necessarily have to be awake, but that they have an intact respiratory drive. Uh, you can still possibly use this with a trismus patient. It might be an option, and it is still one that they test on, and that you should know how to do. We kind of went over this in the lab. It is it's a technique. It's like I said, it's kind of fallen a little bit out of favor just because with the advent of paralytics and even just induction with what we have out here, with just that kind of the DAI drug-assisted intubations, we don't really need it that often these days. You might run into a situation where it might be ideal. John Osborne, the clinical director for for community, pretty well-known medic in Vegas, has worked within Vegas and EMS since the 80s. Old timer, great guy if you haven't known him. But he was telling his story the other day, talking about it, and it was had a 16-year-old girl, airways closing, still breathing, ended up using a technique that one of his former FTOs back in Colorado had kind of showed him, and it definitely worked. You have to. We don't have all the devices to normally make it work very well, particularly things like. So the BAM device is this little whistle that goes on the end, and so it lets you know if you're right above the trachea because you advance it through the nostril, slowly move it down, and as it's going there, you should hear with that BAM, you'll hear the sound of the breathing as it goes in through the tube, and it'll make a little whistling sound at the end where you connect the mask is where the BAM connects. The other thing that's really useful is what they call an endotrol tube, and it basically has this little ring that kind of, as you pull it, it basically connects to the distal end, the part that goes in the trachea, and it curls it. So you pull that little ring attached to this little cord thing, kind of like a toy, and what it does is it curls that, and so it really allows you to get into that anterior type airway. And even if it's not, and that's where some agencies will still carry endotrols just and use them on a normal tubes because it does allow you to get a little bit more anterior with your airways or deal with some of those more anterior airways. So endotrols is still kind of cool, and you see some of those around, but I don't know anyone in the valley that currently uses those. Being said, useful device. I've been part of one airway attempt, and it's because we didn't have induction meds, and we had a bad head injured patient when I was a brand new medic and had to kind of try and figure out one. We were not able to get it, but luckily a few minutes later, flight crew landed, RSI the patient, no issues, and RSI made everything so much easier. Both paralytics and even just induction, drug induced would DAI, a drug-assisted intubation, would have been useful for this. But typically, it's either conscious or at least that respiratory drive that a patient has to have, just because we have to. Even if you don't have a BAM, what you're trying to do. So one thing you do is kind of curl the tube a bit around your fingers to try and get that real hockey stick type one. We're typically not using a stylet with these. So you just want that very well bent that tube with a curve in there, because the only option that we really have, we're not able to control it very well. It's a blind insertion technique, but as you slowly move the nose through the nasal trachea, you move down as it gets close to the trachea, you'll see the condensation start happening in the tube. That knows you're in the right spot. And then one technique that John Osborne was telling me, that the guy taught him, is right when he knew he was very close and the condensation was there, he partially inflated the cuff. So when the patient took that breath, because they have that intact respiratory drive, they basically kind of sucked in the ET tube into the trachea, confirmed placement, and got a tube on a closing 16-year-old's. Pretty cool story. One of those other ones, he's like, it is one of his most coolest tubes that he admitted that he had got in his career. And you don't get those opportunities very often. You probably don't want those opportunities, and we don't need them these days that much, which is it's kind of nice to have some of these other devices that allow us to medications and devices. So, but definitely a bit more of a skill from the past. So typically you're going to want to go with one size smaller than you previously had. Ventilate, try and get them pre-oxygenated as much as possible, much like any intubation attempt. And then you're going to go ahead and make sure it's well lubed and start going through the finger flange towards the nasal septum, much like a NPA. And you're going to kind of go push it down in there. And as it gets close, with that endotrol, you can kind of cause the tip of the tube to move anteriorly, and so you can hope to get a better chance to go in the trachea. And then and like the one technique that John had said with that inflation of the device, the partial inflation of the cuff, it basically made it like a sail and allowed the breath to just pull that tube in, and he said it worked like a charm. That's the only one that he'd done, and that's 30-40 years of working in EMS. So, and if not, try and go out. If that doesn't work, once again, we're going to look at moving to a crike pretty quickly. Possible complications: epistaxis, which is the bleeding of the nose, which we can imagine, sinusitis, infection and swelling of the sinuses, vagal stimulation causing our patient to brady down, injury to the nasal septum and turbinates, probably going to happen a bit. Be very cautious in patients that have a head injury. Don't do this in a patient with a basilar skull fracture, much like that OG-NG. That is a contraindication. If there's any indication that there's a basilar skull fracture, we have the raccoon eyes, anything like that. It can cause vocal cord injury. Any tubes can, but even more so when you're blindly inserting a tube into the trachea. But if you cause vocal cord injury but get a tube, I'd rather get a tube no matter what than well, hopefully not permanently damage the cords. But they're so light because we got an airway somehow. Avulsion of the arytenoid cartilage. The cartilage that one of the important landmarks as we're going into it. We can imagine how that easily happens. And then intracranial tube placement of tube if a patient has a basilar skull fracture. So, being said, in class, we'll watch the video. Face to face, this has some practicality as well these days. This is another one that you might use in a position inside of a car. This is one that we used to do with for CHF patients, because as soon as you laid them down, they'd want a code on you. And so we'd use these for CHF patients for a few different ones. It has some practicality still. And as you can see here, they're doing it with a King Vision, because you're just using it to guide in, and a King Vision is probably a great way to do this. I know it probably doesn't sound like it, but and this is the one that I told you do hold the blade in your right hand, and it works, and it helps with sometimes C-spine immobilization, particularly like ones like I was saying with extrication. Patient might still be in a car, things like that. And this is the video that we'll watch with a normal blade in class, kind of watch them do it. And this is actually from PHTLS. All right, so next we're going to talk about cricoid pressure. You're going to see some people who are adamant that cricoid pressure is the greatest. Cricoid pressure, there's a couple different versions of it. One version has some evidence that works, and that is the burp method, the backwards up and right movement. The other one of Selleck's maneuver has been found, and we'll watch another video in class that kind of enjoyable. Uh, Found that it works not very well at all, and there's a lot of inconsistencies, and we'll talk about that one a little bit more in class. Um, but it's decent. We'll watch it after the movie. So there's a couple different versions of this. Like I said, the backwards up and right works a bit better and has ways to work. I tend, even then, unless I really need it, I tend not to want people to use it. Sometimes you're going to get some providers that was like, here, it looks like you need some cricoid pressure. Start pushing down, and in fact, it can actually cause vomiting, particularly when you talk about like the Selleck's maneuver, which is just straight backwards pressure, because you're just putting pressure on the area, causing them to cough, possibly vomit. Not ideal. So we'll go over cricoid pressure a little bit more in class with this video. Pretty interesting video. Finally, we'll talk about, so most of the time when you look at a lot of evidence involved with using cricoid pressure, they got a little bit better views on the Cormack and Lehane views, which is the view that you get with looking at a patient from a laryngoscopic view, and it can improve it if done correctly with the occasionally. However, it has a lot of side effects and a lot of issues, and it's not very consistent. It's not always there. Backwards up and right is a little bit better. Typically, it required longer times to intubate and more frequent intubations exceeding 30 seconds, and they had more issues involved or with them than the patients that they didn't use it on. So there's quite a few studies that show it doesn't work. However, you might run into a doc or anesthesiologist, and there'll be times where using that burp method actually is effective. The Selleck's maneuver, not as much, and we'll talk a little bit about the difference between the two. But Selleck's is basically just straight pressure down, and it has shown not to work very well. So we'll go, like I said, we'll discuss this a little bit more in class, and if you guys have any further questions or want more information, we'll talk about it then. The burp maneuver is the one that we're going to spend a little bit more time with because it does have a little bit more efficacy and a little bit more evidence of working. From anecdotal, a little bit of mine, I still haven't had it be successful many of the times, but I have had it be successful. The Selleck's maneuver, almost never. But basically, you're going to improve visualization of the larynx directly by simple back and up pressure on the larynx and a little bit to the right. This pushes everything right into the view and tries to help. So the burp maneuver does help, but I still don't want people tend to just jump into my airway space if I'm taking an airway, unless I ask for it and if they should know what they're doing with it. So by backwards up, right, and posterior pressure on the larynx, you just place the larynx backwards and upwards with a little bit of right on the cricoid pressure, thyroid cartilage pressure, and basically it pushes the thyroid, the whole thyroid cartilage all the way back and up, and allows a little bit better views. And so you're going to see an ER doc might go, oh, this patient could use that, and they might help you out a ton. But once again, I'm not a doc in the hospital. If they do that, roll with it. And sometimes they might just all of a sudden give you this fantastic view. It's a great time, and that's it being done correctly on the right patient. But sometimes it causes the patient to vomit and other issues, and that's where we really got to be cautious with. We'll have one quick video on this on how to kind of show you how to use it correctly and how it can be effective. All right, radial laryngoscopy. I know we went over class on here, but we're going to talk about a few different ones. The most common out there, the CMAC, the Glide Scope, the King Vision, which is used by AMR Community Medical West, McGrath used by LVFR, AeroCare, it used to be AirMed. It works pretty decent. Some of these are more effective, some are nicer, some are a lot more expensive, particularly the CMAC is typically the most expensive. and the glide scope's usually not too much cheaper. We're talking like $16,000 each, where McGrath or King Vision anywhere from like 12 to 1,800. So you're talking almost 10 times the amount of the price from a McGrath to a CMAC. CMAC and glide scopes, typically they'll have both in the hospital. Many times at Spring Valley, the one that they have around the ER is going to be a glide scope. I will review this again right before clinicals and give you guys some practice. The rigid stylet, there's a unique technique you can use or you need to use with it, and it's a little bit different, particularly with the hyperangulated blade. Many times in the hospital, they'll use DL most of the time and only use video for the hyperangulated blade portion. And the hyperangulated blade uses a little bit of a unique different technique depending on which blade you're using. For the CMAC, they have a glide scope. I forgot what, or a D blade for the glide scope. I forgot what it's called, but it's a slightly different angle. The McGrath has the X blade. It's not as hyperangulated. King Vision is nothing but a hyperangulated blade. And so we'll talk about some of the pros and cons with that coming up here in a minute. Or the next slide. All right. So advantages, you have precise visual control. You can confirm it's in. With the CMAC, we would also take video of it, as well as we had to attach a picture of the tube through the cords and attach it to our chart when it's flying with Guardian. Shorter times for most innovations, greater success rates. It's a great teaching tool, both in the moment as we're intubating, and then if like on an internship, and then also being able to show different airway areas just from an instructional point of view, and also seeing, hey, small corrections, your FTO, or example me, like when I can see the video, other students can see the issues that you're running into, and how to make small adjustments, and how all of a sudden all that lines up. So it's a great training tool. Disadvantages, particularly with the hyperangulated blade. There's no correlation between your laryngeal view and your intubation difficulty. You might have a fantastic view and not realize it's going to still be a very difficult airway to get. And I think we kind of showed this many times, as many of you guys during the airway attempt. If you haven't had a chance, you'll do that in a lab soon, or we just did it, and you'll see that you have those really good views. Beautiful views. However, the tube goes, you can watch the tube go right in the esophagus, and you have difficulty getting up. Fogging the lens or contamination of the lens by fluid. Now, we will try and prevent this as most of the time we're able to with the salad technique, which is suction-assisted laryngoscopy, airway decontamination. You don't necessarily have to remember what that acronym means, other than the technique itself. The technique's very useful, particularly in very vomitous, bloody ones. And we should be using the salad technique in every single video laryngoscope, because it also helps prevent the fogging, because the suction pulls away a lot of that humidified air, and makes it it all of a sudden makes a tube that you may not have, or if in the past where your tube may have been fogged up and contaminated, or your camera would be, now it's not a big issue, because we're clearing the oropharynx from both secretions and fluid, as well as that humidified air. So it works pretty decently. They tend to be a little bit more expensive, and especially when we talk about it takes extra training to use it decently effective. It's what's nice kind of about like the McGrath and the CMAC normal blades, because they do allow a little bit of you being able to use it in a normal manner, which is kind of nice. You can use a Mac 3 on there, and then if all of a sudden your blade gets fogged up, you can just go directly to DL. The hyperangulated blades, you can't really do that, and that's an issue that many times people complain about, is you can't use the blade, a DL blade, or sorry, hyperangulated blade, like you normally would. You can't use it as a DL blade, direct laryngoscopy, like we typically would in the past. So that's an issue that kind of comes up many times. But the McGrath, kind of nice in that it acts just like a normal blade, if all of a sudden your camera gets fogged up, you can still use it so long as the light's still working, just like a normal blade. And even if the light's not working, you can still kind of make do with what you have. Reason that some of the why some agencies like those blades, and it's a downfall of the King Vision in that it doesn't have that capability. It only has that hyper angulated blade on it, at least the versions we have out here. And so if you lose your view, you typically can't use it as a direct view. So we can see the difference of the hyperangular blades. I believe that's a glide scope blade. I forgot the name of it. It's not that important but you'll just see some of the hyperangular blades have varying angle differences. Like I said, the X blade's not that angled compared to hyperangled compared to some of the others, but it still is. It's an effective blade. From what I heard, that's one I don't have. While I have experience with the McGrath, I don't have experience with that hyper-angulated blade, that X blade. We're working on that, and we'll try and get one in here soon to you guys. We're working, so if we don't have one yet when we go through this, it's a process we're currently working on and trying to rectify. Particularly since the glide scope's not as we might get access to one, but we're most likely not anytime soon, just because of the price tag for just training purposes, unless we get someone to donate one. It's also why that price tag is why you don't see it on companies that have a large amount of units. So almost anyone in the valley, from fire to privates, just because it's so hard to or so expensive to use. So that being said, the devices that have the standard blades, CMAC, glide scope, McGrath. There's a couple others out there that have some of these options, but the standard ones, those are blades that you might see some of these. So that being said, King Vision only hyperangulated. Kind of talked about those. The idea is, so typically we're going to line up all three of our axes. The blades that have the ability to do both, I said, are some of the most useful, because if all of a sudden your camera gets fogged up, even using the solid technique, it can happen. Sometimes there's just so much blood or whatever else in there. It's not even necessarily fog, but particularly the contamination. If that happens, we can still use our blade as a DL blade. But you can use a Mac blade a little bit as a somewhat kind of hyperangulated blade, a Miller not as much. But even then, we can just see if our patient has any type of nuchal or unable to move their neck mobility, whether due to fusions, kyphosis, or they're in C-spine precautions. That hyperangulated blade is really helpful, and it's also really helpful on very anterior airways. If we identify that this is going to be a difficult airway, that's the time to try and move to a blade that has video in general, but especially a video that has a hyperangulated blade. Cool. So you can see the King Vision at the very top. That is the D blade for the CMAC. Next down, very useful. Then you have your Miller or Mac and Millers. So the hyperangulated blade specifically, so you have that improved glottic visualization, especially in scenarios, limited neck mobility, so no need to align the oral, pharyngeal, and laryngeal axes. Allows others of you screen intubation difficult to pass the tube despite improved glottic visualization, unless you can get it a little bit better if you have either a rigid versus stylet for some of those devices, or the channels you can kind of run, but you have to have some more familiarization with your device to know which you need to kind of work with. And so we'll go over there, and deterioration of skills. And if you always use video, which is why a lot of people always will still practice DLs on certain patients, sometimes codes where they realize the patient might not make it. Not to say that's ethical or not, but that's one that some people will go, hey, this patient's going, it's a code, it's an 8-year-old, I'm going to use a DL attempt to try and keep my skills up. If it's a patient that we really need to, has a high chance of a quality of life afterwards, particularly younger patients, many times that's where we don't want to take a chance just to go, oh yeah, I can use my DL blade on this patient. Like, we should probably use everything we can to give our patient the best chance of survivability. I talked a little bit about this, how your standard geometry, if you're using a normal CMAC, can help because it does help better visualize. However, when we're unable to move the neck, that's where particularly those hyperangulated blades are very helpful. If you're using a normal Mac and type blade, go ahead and use that same procedure to try and help you out, but kind of go through there. So here's some extra tips. So the blade can be inserted in the mouth on either midline or following conventional along the right side of the tongue and then moving everything to the left side. Watching the tip of the blade as it's inserted in the mouth. The best part about the thing that should take some of the longest with the video compared to a DL is a little bit of a slow insertion. By burying the blade to the very bottom, we have a chance of contaminating the camera more, even with the solid technique. So going down, identifying where we need to go, identify our landmarks and where we need to put the tip of that blade. With the King, showed you if you put that right in the molecular, like a Mac blade goes, all of a sudden it lines up everything nice and easy. And if it has that channel in there, just put the tube down the channel and it just goes right where it needs to go. How you hold the tube, instead of holding it down in the middle like we do for our standard tube innovations, instead you hold it at the very top. And if you notice, there's the glide scope rigid stylet in there. It's the one I have in class and I've showed you guys. Pretty useful. I like it. I have a lot of fine control of that motor, of the tip of it, and because it's rigid, it's typically like aluminum, and you can make a small little movement with your thumb, and it moves the tip around very easily. We'll get some practice with this prior to you guys going into clinicals. The hyperangulated blade, the most common error is too deep of one. If we look at that bottom one, we can see kind of where it's placed. I think for those of you guys who practice and buried it too deep, you're like, oh, this is a fantastic view. However, we can see that esophagus a little bit on the lower side, and that's usually where the tube wants to end up. All we would need to see is our dontoid cartilages. You can see that proper placement of the tip of the blade in that top picture. You don't see the tip of the blade because it's in the vallecula and it's pulling up, and which is hitting that tendon, which opens up the epiglottis and allows almost fantastic placement directly into the trachea. Once it's in there, use your left hand to kind of secure the device, particularly with a rigid. You're going to pull the rigid out almost the same way, and it's going to go right towards the chest. And then we're going to secure the device like we normally would. So with a rigid stylet especially, I tend to make sure my cuff is inflated so you have a less chance of accidentally pulling the tube out. And I keep my blade in there until I'm ready to secure it, just so, particularly with the camera, then everyone's seeing it's still in the correct place. So you see that you pop it up with your thumb and then you just move it towards the tip of the chest. Bushi is typically not recommended for a hyperangulated blade. It can work for some. I'm not a big fan of it. It can work. If the tube is catching on the edge of the cords or anything like that, if you rotate it 30 to 40% either clock or anti-clockwise, many times it rolls that bevel off the cords and right, or the odontoids, and right into the trachea. So if you're getting caught on the cords, particularly the tip of the blade, that is a great just that half rotation many times. Also doing a little bit of a lifting technique works pretty well too. Lift the weight with your blade still in there. If you lift up a little bit as you advance the tube, it helps that process out. Some disadvantages because of its unique shape. Special care should be taken when inserting to avoid dental or pharyngeal airway. Blade handle may be needed to angle towards the patient's chest and turn slightly to facilitate atraumatic insertion. Another one someone had just recently brought up, and I thought it was a great thing to pass on, was kind of angling at about a 45-degree angle as you go in, and then rotating it once you're inside the mouth, particularly if they're trismusing down some. Seems to be a very effective way to try and get in some of those smaller mouths or mouths that might have some trismus going on. Another issue is you might have difficulty passing into tracheal tube despite improved glottic visualization. We talked about that. Um, if you have a better placement further back, if you're having a hard time getting it in, almost every time just kind of move the entire blade back the way you went in, and most of the time it's gonna get you a better view. All the things we talked about. All right, we're gonna go over solid technique real quick. This is gonna be a skill station. We're going to go over it in lab. In lab, it's basically going to be an airway, our dirty airway head. It's going to be attached to a aquarium pump that pumps roughly about a gallon a minute, and it's going to constantly pump fluid through there. And when we do that, you're going to doing the correct solid technique. You should be able to keep the entire airway trachea clear of fluid, and your camera should not get splattered upon. Some of you guys will still get some fluid on the camera, but that's usually from burying that to the camera a little bit too deep, the blade a little bit too deep. This should be used for every video laryngoscopy to prevent degradation, fogging, and decontamination of the video lens. It's useful during direct. I always have suction out, and many times I will use the solid technique many times. I didn't add it into the beginning of your guys' part because it adds a extra couple factors in there. But as you become more proficient, if you can keep that airway clear, it is a super useful technique for all innovations, not just video and difficult airways. So it's developed by Dr. DeCanto, and he also then developed the DeCanto catheter. I don't know if we actually have full DeCantos. The big stick is the one we typically see. That the interesting thing about the DeCanto is it's hyperangulated to try and match some of those hyperangulation blades. The big stick is a standard one with the same angles as a yank hour, but they have very similar suction capabilities. So the DeCanto, I might have talked about this previously in class, but the yank hour is initially from Dr. Yankauer, over 100, about 100, I think it was 1908. Developed the yank hour, and it was developed by an ENT doctor, Dr. Yankauer, for removal of clots during ENT, so ear, nose, and throat procedures. It was not meant for gross contamination gross decontamination of airways with a ton of different fluids in there. It's meant to pull out small little clots and other things in there. The other thing you can use, so ideally you're either going to use the big stick or the DeCanto catheter. They just can pull out a lot more fluid, and if we look over there, the DeCanto, if you just due to the size of the diameter of the suction catheter itself, very similar to the DeCanto, they're almost identical. They have the same basic suction catheters. The one thing about the big stick ones that we have in here for training is that they do have the suction hole that you need to place your thumb over or put a piece of tape over for this procedure. But there's a number of different issues with this as opposed to the DeCanto itself, which is probably the overall best one, but very effective overall. And we can just see for pure water, it pulls up quite a lot more syrupy, that more viscous. It's still the DeCanto and the big stick. They just outperform all the other catheters just by the ability to pull more fluid through that suction device. A couple issues I've seen though with some of those bigger catheters, if you have a weak suction device, because it has a bigger suction hole that we're trying to suction out of, you might have issues occasionally trying to pull more than the suction device is able to really compensate for. I haven't ran in person, but I've talked to people who have that I've worked with in the past and said if the suction device doesn't have enough suction power, or sometimes the canister itself is too small, it causes some issues to have. So we can see typically it's a bit better one. If you haven't seen it in class, you should, but here it is. And so you have a yank hour. You have on the very top, DeCanto is the next one down. You can see how much bigger that is. They have a 10-0 tube right next to it, which also provides another device that we could look at trying to use, because if you use your meconium aspirator, connect it to the side that you would normally connect a BVM. The DeCanto is made, or sorry, the meconium aspirator is actually made for that for neonates, but you can use it, and all of a sudden you have a very big tube, that suction tube, that's very similar. As big as one you have, an 8.5, 8.0, and they work really well to try and do that if all of a sudden you don't have a tube. The other thing you can try and do is if you have a yank hour on your truck, like a traditional yank hour, and it's just not pulling enough fluid out of there, you can just disconnect the yank hour and put the tube directly into the mouth, and it'll pull out a lot of that bigger ones. There's some stuff on here which you can do with that. Soft suction can work in there as well. It's just not as effective. If it's an OG, you can do that, and then you already have an OG ready to place and just further advance down the esophagus. Have your bougie on standby, video useful, have your backup ready when you're getting ready to go for it, when we're getting our equipment ready. So other equipment, have your rescue airway out and ready just in case, have a tube securing device, NG-OG, and then your BBM and end-tidal with your end-tidal attached. So this is kind of like what the device we have kind of going on. We have it kind of going through. This is a little bit cleaner. Our airway head has a couple areas where it leaks out from. So you're going to see a little bit of tub in there underneath ours to try and catch some of the fluids. We don't have as much cleanup, but basically how it works. This is how you can set up your own device. Or you can build one yourself. Just have some type of pump in there, pumping fluid up through the esophagus, and then filling up the airway. So how we do the salad is you open up the airway with the scissors method or something similar. You lead with suction. Suction's in front of the camera. You're slowly clearing the airway as you go, identifying the locations, and then uh, as you clear the decontamination, once the blade is in position, you transition the suction to the far left side so it's out of the way, because the right side of the mouth, the oral pharynx, is going to be where our workspace is, where the tube's going. And you bury the suction into the esophagus and you leave it there. This is why if it has a suction hole, even if you're using a yank hour or like the big six have that little suction hole, you need to put your thumb over to initiate suction. If it has that, if you put a tape on prior to that, then you're just hands free. You grab your blade, your tube, and then you intubate your patient like we were doing videos the other day. Another kind of view of that from A down to J at the very bottom. Suction followed by video. As it gets closer, you bury the suction catheter into the esophagus. You start suctioning your patient, you advance the tube, place it, and then you pull the suction out at the very end and go through. So after that, after it's in the correct placement, you inflate your cuff, remove your introducer device, whether that's a bougie, stylet, or rigid or semi-rigid. Then you remove suction, secure your tube placement, confirm again with ETCO2, place OG and G. All right, a couple rescue techniques. If there's gross contamination, a ton of blood, vomit that you just cannot identify where the trachea is at, you're just trying to suction it away, something like esophageal varices, where there's just this crazy amount of blood in there. Follow the bubbles down if there's still any bubbles coming up from the trachea. Once you get there, and I'll show you guys how to do this, you advance the, it has to be a big stick or a decanto into the trachea. You put your suction device in the trachea, disconnect the suction, and then put your bougie through either of those two larger suction devices, and then you remove the suction catheter, and you then advance the tube over the bougie, and you should be in place. This is not a primary intubation method. This is a rescue intubation method when other things are not working, and you have this crazy gross contaminated airway that you're unable to fix otherwise. It's how you kind of work that, and I'll show you in class. It's pretty easy to do. Don't use that as your primary intubation. Your FTO might have a stroke. One of our students tried that. I had to explain why to both the student and the FTO, and the student of don't use that as your primary intubation technique. All right, and so we'll go over this technique a little bit more in class, and it's kind of the same. Standard yank hour can be used for the solid technique, as can a soft suction catheter. They're just not going to be able to pull up as much, and you can't use that rescue technique with it. So, with that being said, it can definitely work, or you just go ahead and remove the suction or the catheter at the end if you need to use just the suction tubing placed into the oral pharynx, and I'll show you how to do that during lab as well. Same as this. Another one you can do that I've seen as well is placing an NG-OG in the back, particularly if it's just a little bit, and leaving it there. And then once you get the tube, you can just further advance it, and all of a sudden you already have your OG&G in place. It works pretty well. All right, so salad technique. 3 simple steps in the end, guys. You lead with suction, you park suction to the left, and you place the tube. It's a lot easier than probably all the pictures and diagrams I just showed you guys. It works, easy to use. You'll probably forget about it sometime, hopefully when you see a really bad airway, or anytime you're using video, lead with suction, and it's going to make your life a lot easier. Any questions? Go ahead and ask in class. I'll talk to you guys later. Never mind, I lied. I thought we still have our crike stuff at the end of this one. So we're going to watch a cool video in class on a live crike, but a crike. We're going to talk about both surgical and needle crikes. Traditional needle cricothyrotomy is not that great when it's 14 gauge and a jet insulator. That being said, it worked. The new ones work pretty well. They are the equivalent of a 4.0 tube. Not ideal. That's a pediatric, it's a smaller pediatric tube, but it works because it oxygenates and it ventilates, as opposed to the old needle cracks. All it did was oxygenate. It moved air in, but didn't really allow air out. This technique actually, with our quick trachs, works pretty well. All right. So definition of insanity: doing the same thing over and over again and expecting different results. That's not always necessarily the full definition, but heard this quite a few times. But still the same. If you're not making any changes and you're doing the same thing, um, you can't expect to have a different result. So we're going to look at a needle cricothyrotomy. It's also known as a percutaneous transtracheal ventilation or a translaryngeal cannula ventilation. Needle crikes, same placement, location, and landmarks we're running with. We're just sticking a needle in. If you see this typically on an airway test, they are not talking about the quick trachs, that is that 4O tube. Most of the time, particularly with the translaryngeal cannula ventilation, they're talking about the 14 gauge and a jet insulator, and that's why it's a last resort. As opposed to what we're using here, they're finding it to be pretty quick and easy, and people are a little bit more not as hesitant to go move to a crike, which is a good thing when we're having a failure to ventilate and a failure to oxygenate situation. All right, we look at our location. We have our hyoid bone up top, thyroid cartilage, a big cartilage, our voice box. Our thyroid cricoid thyroid ligament is right below it, A. That's where we're going to do a cricothyrotomy. The other big movement in the other little hill, the cricothyroid ligament areas where we're going to be placing our cricothyroid, our cricothyrotomy. The cricoid cartilage below it is the other landmark we're looking for. Tracheostomy, what we see a little bit later, just because our kits say quick trach on them, we're putting them in the cricoid thyroid cartilage, not where we put a tracheostomy. Tracheostomy is a surgical procedure done in a non-emergent fashion. A cricothyrotomy is an emergent procedure, and that's why we do those in the field. Tracheostomies are typically done in an OR. So we go ahead and line up everything as best we can. And this is with a 12 or 14 gauge over the needle catheter with a 10 to 20 millimeter syringe and a jet insufflation device. We'll show you on this. You guys still might have some of them on your ambulances. The jet insufflation device, and all it does is push oxygen in under high pressure down in there. Patients supine, stabilize the larynx, insert the needle downwards, advance catheter over the needle, hold the hub, secure it, observe chest. Good luck trying to see a chest rise with this. And then ventilate at a rate of 1 second. This is okay. The reason you have a syringe, particularly if you have fluid in there, is so that when you get into the trachea, you should see air come up through the fluid. But even without fluid in that syringe, if you have just an empty syringe, you pull back, you might get some blood. Cricothyrotomies can be very, very bloody, and we'll watch this video at the end to show you how bloody they can be. Even a needle crack. So you getting a little bit of blood back's fine, but you're going to get mostly air with maybe some blood splatter in there. That's fine. If you're pulling back and you're drawing just blood, let's hope it's not bright red blood and you didn't just hit a vessel. But if it's not, the syringe isn't wanting to pull back, that means you're not in the right location. So the extra area that we're looking at, we can see right there, we have our thyroid cartilage, we have our cricoid thyroid membrane, and our cricoid cartilage. That our aim is for that cricoid thyroid membrane. That is where we're going for both surgical and needle crikes. We can see a couple of different placements here. We'll watch this in class in the jet insulator. It's a thing. All right, the commercial device, we just kind of went over there. This is what we have in class, how we do it. Sometimes they're cuffed, many times they're not. They don't need to be cuffed. Sometimes the cuff makes it a little bit more difficult. Many times the cuff gets caught on the tracheal rings as it's going inside, and it causes a number of issues that I've found, even on like a cadaver lab and things like that. And so that cuff will rip. That's fine. We can make do without a cuff. The ones that we have here and that most of you guys have actually don't even usually have cuffs, which is fine. The cuffs aren't needed in this necessarily. We're not worried about it maintaining placement, things like that. So we're going to go over there. Same thing, same place. Cool. We'll watch this video in lab or in class. And so advantages, it's a minimally invasive surgical procedure. It is very invasive. We are sticking a needle into someone's throat. But we stick needles other places. We cut places. We do things. It's invasive, but actually, and particularly the needle, have very little surgical things. I still are scars, and they can do things. And they have a couple other techniques that they'll talk about that we don't necessarily do here, but such as like a retrograde intubation via things. I can briefly talk about it, but we're not going to go over the skill itself. So some other issues though that can happen is because we're trying to put a lot of air through a small hole, we have increased pressures that increase air pressure. So when that happens, one of the issues that can come up in general is that it can cause trauma to the surrounding tissues or barotrauma just because we're using so much air pressure to get through those tiny little holes. So effective, but it has some side effects that we have to be aware of. And then um, it's a temporary emergent procedure, which we kind of talked about. So we'll look at a couple of the other options that we have going for us. The surgical cricothyrotomy, we do train that here. We do teach you guys how to do it and how to do it correctly. It is an approved for the state of Nevada, but it's not for Southern Nevada Health District where you guys are licensed through. But if you guys ever go to any other part of the state or the flight programs, surgical crikes are absolutely used and needed, are more effective because you can use a much larger tube. It's fine. With the new quite quick trachs, it's not as big of a difference anymore. But you go over to Arizona, parts of California, but almost all of Arizona, uh, cricothyrotomy, surgical crikes are the what people use because it is a better airway. Being said, the ones we have are effective. So I don't necessarily see this one change unless there's a weird supply equipment issue. But unlike paralytics, which I could see us getting in maybe a timely fashion, who knows, maybe never. But surgical cracks, probably not. It's fine. It's everything works. Um, Same locations, but what you are going to need is a scalpel, typically like a 6.065 tube, and some type of securement device, but you can even use just our standard commercial securement device. Those are some of the big ones. There's some other things like a tracheal hook that you can use and things like that. So it's a procedure by paramedics authorized to perform in some EMS systems. It can provide ventilation oxygenation when airway control is not possible by other means. And we have a couple commercially prepared kits here. Thank you to one of our students from Creech. Brought one up last time. I believe it's either from Creech or maybe from county up there. But they use it. It works easy. I've done them on live tissue labs for the doing military-esque stuff, and for on like pigs, things like that. It's a pretty interesting procedure. So we'll go over some of this. Same location, and this is going to be, as much as I can talk about this here, it's going to be a lot more easier to show you guys when you guys get practice on it. Either way, if you ever see a crike, whether it's our quick trach crike kits, like the needle crikes that we use, or the surgical crikes, if you ever have a training kit that's out at station, or you guys are doing a training on it, get as many reps as you can. This is a very, very low frequency. Many people will go their entire career without getting a single crike, and that's a good career. If you get a few crikes, all right, you've had some bad airways. If you get more than like 5, you need to go back to get some more training on how to intubate a patient. So typically, there's exceptions, but you're going to go ahead and locate it. You're going to stabilize it using your non-dominant hand. You're going to swab the incision site as best as can if you have the opportunity to. If not, at this point, it is an emergent situation, and we're going for it. And we'll see in the video. You're going to make first a vertical laceration, or not laceration, incision. And then you're going to turn your blade, and you're going to make a quick push in. And then you're going to typically keep either, you can put a bougie in there immediately. Some people put their finger in there so they don't lose it. If there's a lot of adipose tissue, that might not be a halfway bad idea. But the video, even when Dr. Weingart talks about it, it's not necessarily needed. Typically, 6.5 is a great one for an adult. You're going to hold open the side. You're going to advance the tube. You're going to secure it. That is a nice clean after it's already been done for a while, because that's hardly bleeding at all. These are very bloody procedures, and we're about to see a video that shows us why in class. Some possible complications: the prolonged procedure time, possibly. If you have everything set up, you can do it relatively quickly. There's some pretty interesting kits that can make this really simple. I went once on a cadaver lab, went from zero, from opening my kit to secure placement within about 35 seconds. If there's already a tube in there, something's going wrong, don't try and remove it. That's what that's saying. We'll watch this video in class. It's amazing. All right.